Hi, my name's Amy and I'm here to talk to you about my story. I had my little girl at 28 weeks gestation and she weighed 695 grams. When I had Lily, the doctors explained to me about an intervention that they were going to do, which is called delayed cord clamping. It would last about 1 minute and they would make sure that she was warm, happy, safe, and make sure that I was okay during this time. When they told me that, I felt very relaxed and happy. I was not worried at all during that 1 minute. I knew that Lily was happy and warm and safe, and I knew I was as well. And I think that I'm so grateful for the doctors explaining it to me beforehand, so I knew what was happening in their moments and why it was so standstill for 1 minute. So I am really grateful. I knew it was an intervention that was going to help save her life, and I just think it's incredible. So thank you so much.
The Optimal Cord Management Quality Improvement Toolkit was launched in December 2020, and the working group for this included a multidisciplinary representation from a broad perinatal team, including neonatologists, neonatal nurses, midwives, and obstetricians, and, as you've already heard, some important contributions from parents also. The context for this toolkit is that it provides an important addition to the 3 other British Association of Perinatal Medicine quality improvement toolkits within the perinatal optimisation pathway, with previously launched quality improvement toolkits in antenatal optimisation, neonatal normothermia, and the provision of maternal breast milk. It is important to emphasise that this toolkit is not a guideline. Instead, its purpose is to support the implementation of optimal cord management in all preterm babies less than 34 weeks gestation, defined by waiting at least 60 seconds before clamping the umbilical cord. It is fundamental to this aim that we have used the term optimal cord management throughout the toolkit rather than delayed cord clamping, which may erroneously suggest the alternative that an important intervention has not been performed on time. This toolkit will provide the evidence base for optimal cord management in preterm babies less than 34 weeks. It will facilitate units in interrogating their own data and processes in order to undertake selected quality improvement activities suited to their local context. It will also assist units in interpreting and monitoring the results of their quality improvement activity in this area, and provide and signpost resources to facilitate quality improvement to improve optimal cord management in all preterm babies less than 34 weeks gestation. The evidence base for optimal cord management will be presented in more detail later in this webinar, but by way of summary, optimal cord management reduces death in preterm babies by nearly 1/3, with the number of babies needing to receive optimal cord management to prevent a death around 30 to 50 overall, but this may be as low as 20 in the least mature babies. Optimal cord management also increases blood pressure and reduces the need for inotropic support, as well as reducing the need for blood transfusion. And with the evidence base for those benefits, optimal cord management is recommended by a number of national and international organisations, including the WHO, ILCOR, NICE, and of course the British Association of Perinatal Medicine. Within the UK, there are a number of drivers in terms of guidelines, standards, benchmarking processes, and professional interest groups. Once again, emphasising that the toolkit is not a guideline, there are some suggestions of what best practice may look like, with consideration of the equipment required, preparation, positioning, communication within the perinatal team, provision of thermal care and respiratory support for the baby before the cord is clamped after at least 60 seconds following birth. The toolkit describes the quality improvement journey in the 5 standard phases. Phase 1 being defining the problem, Phase 2, developing a shared purpose. Phase 3, planning and implementing change. Phase 4, testing and measuring improvement. And Phase 5, embedding and sustaining change. For defining the problem, the toolkit suggests the use of standard quality improvement tools, including force field analysis, fishbone diagrams, case reviews, Pareto charts, and driver diagrams. Phase 2 involves developing a shared purpose and engaging a wider perinatal team of stakeholders. It is suggested that maternity operating theatre staff, including anaesthetic teams, are included in the stakeholder group, as well as parents, of course. Phase 3 involves planning and implementing change, starting with a project charter. Again, established QI methodologies such as PDSA cycles are suggested. Phase 4 is testing and measuring improvement, collecting data with respect to outcome measures, process measures, and balancing measures. Examples of each are given for this particular toolkit. Data collected can then be used using a selection of visual tools, including run charts, statistical process control charts, and days between charts. Phase 5 is embedding and sustaining changes into practice by disseminating information about successful change and using exception reporting to review less successful outcomes. An exception reporting template is included in the appendix of this toolkit. At the end of this toolkit, there are links to the generic BAPM quality web pages that provide resources to enable you to plan your QI project, investigate your current practice, plan your change idea, and interpret your data. There are also a number of other resources, including guidelines, standards, and quality improvement initiatives available.
Thank you very much for the kind introduction. I will now talk to you about what is the evidence to provide optimal cord management at birth in preterm infants. We need to consider what is happening when a baby is born. We have to consider whether the baby needs resuscitation and whether we can enable them to have a physiological transition. And for that, the optimal timing for clamping the cord at birth is still under discussion. Of course, early clamping allows for immediate resuscitation of a newborn infant, but delaying on the clamping or milking of the cord would facilitate transfer of additional blood between the placenta and the baby. And now I would like to think a little bit about what is the physiological transition changes when this happens. So if you just remind yourself about the postnatal changes of circulation which happens at birth, the placental circulation obviously stops if we clamp the cord and cut it. The fetal shunt should normally close, but that can be delayed in preterm infants. The PDA changes from left to right shunt, and there are massive amounts of changes in vascular resistance, and we have an increase in pulmonary vasodilation because more blood needs to go into the baby from the baby's circulation into the lungs. There's an increase in right ventricular outflow, and the pulmonary blood volume as a result can increase. There's decrease in vascular resistance and increase in blood pressure coming up. So overall, these changes contribute to cardiovascular stabilization after birth. Just at the beginning, I would just go quickly through the definitions of optimal cord management and the methods which we can use. So the first and foremost is delayed, or also called deferred cord clamping. That means leaving the cord intact for 60 seconds in preterm infants and up to 3 to 5 minutes in term infants before clamping and cutting the cord. There have been some studies with resuscitation with intact cord, leaving the cord intact and starting resuscitation, such as inflation breaths or intubation before clamping and cutting the cord. Cord milking, also referred to as stripping, defined as repeated compression, gentle compression, and as the cord from the placenta side towards the infant with intact connections, so that more blood from the placenta can get into the baby. And there's another one which is called cut cord milking. That's also referred to as stripping, where the cord is cut, but then the remaining part of the cord is then milked towards the baby in a long segment. So if you think about the blood distribution throughout the pregnancy, about 50% of blood is in the placenta and 50% in the baby. However, towards the end of the gestation, 2/3 of the blood volume will be in the baby. However, if we think about our preterm infants, if you have immediate cord clamping, half of the blood volume for the baby would actually remain in the baby. So if we perform enhanced placental transfusion, more blood flows from the placenta into the baby, and thereby we have more blood which can flow into the baby's lungs, and that can be up to 2 liters compared to 2-liter blood transfusion in an adult. Why is circulation adaptation so important? There's a recent study in pediatric research where people compared blood pressure extremes in babies who had severe IVH compared to babies who did not have severe IVH. So that was degrees 3 and 4. And as you can see in this pattern, babies who had severe IVH had very much changes in the first days of life with increased peaks and troughs. And we think that that might be a contribution to the very fragile vascular bed of the babies. That's another way of looking at it. So the proportion of high and low peak in blood pressure that was higher in the babies who had the severe IVH. So people have done a lot of randomized controlled trials comparing the different ways of performing optimal placental transfusion in preterm infants. That's a trial here by Bacchus, which looked at very immature babies of 22 to 27 weeks gestation and showed that with delayed cord clamping compared to immediate cord clamping, that those babies had higher blood pressure. This is the mean blood pressure in the first 24 hours of life. So it means an improved circulatory adaptation. We compared in our studies in Brighton 4 times milking of the cord versus 30 seconds of delayed cord clamping time, and showed that in both groups the mean blood pressure was increasing over the first 5 days of life, and but there was no significant difference between the 2 groups. That was also babies below 32 weeks gestation. Recently, as I've already mentioned, people are interested in delayed cord clamping and use of a resource tally. So that means you start the resuscitation while the cord is intact. That is just some data from preterm infants less than 34 weeks, the pilot studies from the Netherlands. And here you can see that they had very stable increase in heart rate over the first few minutes of life. They only clamped the cord once the heart rate was at least 100 beats per minute, and the first breaths were established, and the mean cord clamping time here was 4 to 6 minutes. They provide respiratory support if needed and use the bespoke trolley. How about temperature control? People are always worried babies might be getting cold. There's a recent study in near-term lambs, which actually showed that the lambs who had delayed cord clamping had better temperature controls, and that's probably improved also with improvement in circulatory volume. So does the baby actually need active resuscitation? There was a nice study by Anup Kataria published in 2016, where he compared preterm infants born by cesarean section, and they either had both groups had delayed cord clamping, and they either had only tactile stimulation and positioning or got ventilation breaths. But what he found is that actually by 1 minute of age, both groups 90% of the babies were breathing by themselves. So there's only a very small proportion of babies who might need extra active resuscitation if you do delayed cord clamping. So what's the latest evidence? There have been quite a number of meta-analyses published, especially our Cochrane review in 2019. There will be another publication coming out in February 2021 that was done together with ILCO and the Cochrane group, and we now have 42 studies comparing the different methods. Overall, all the reviews have shown that there's a reduced mortality for preterm infants by about 30%. And we were able to look at the group's immediate cord clamping versus delayed cord clamping, and that favors delayed cord clamping with regard to mortality. The same for cord milking, and there's no difference between delayed cord clamping and cord milking with regard to this outcome. With regard to the delayed cord clamping with intact cord, there are too few studies, but there's a trend to favor delayed cord clamping as well. We also looked at the major comorbidities. Here's an example where we looked at effects of cord milking versus delayed cord clamping, and there's no clear differences in the key mortalities like IVH, chronic lung disease, necrotizing enterolitis, hyperbilirubinemia, and peak hemoglobin and hematocrit concentrations. So overall, what are the reported benefits from optimal cord clamping in preterm infants? I've already mentioned the comorbidities. And the main really important message is there's a reduction in hospital deaths by 27 to 30% in all the meta-analyses. So why do we actually cord clamp immediately? There's always a fear there might be a risk of increased hemorrhage after birth. However, that has been disproven by recent meta-analysis, and the WHO is now actually saying that immediate cord clamping is contraindicated. Just one word about term infants. We concentrate very much in this BAPM guideline on babies below 34 weeks, as it works out well with the overall pathway. But of course, you should do delayed cord clamping in babies above 34 weeks, and especially in term babies. And for them, there's an increased total body iron at 6 to 12 months and better neurodevelopmental outcome at 4 years of age. So this webinar today is about the optimal cord management toolkit, which fits very well in the other 4 BAPM toolkits where we want to improve the pathway for the mothers and the babies around birth. And we recommend, we wanted to concentrate really on one method only, so we strongly recommend to delay cord clamping of at least 1 minute in preterm infants. Early cord clamping is not recommended. We recommend that one should develop unit guidelines and their toolkits or examples inside the toolkit, which you could use and try to implement it in your own team. And we recommend to use an MDT approach and also involve the parents. How to do it? There's a nice guidance from Essential Newborn Care by the WHO where you can use a pathway. And if you go through this pathway, automatically 1 minute is over by the time you have taken care of the baby and checked the baby over. So in summary, the mortality is improved by 27 to 30% if you do optimal cord management, but you have to keep in mind that survivors will develop comorbidities of prematurity. There were no increased risks demonstrated so far in all the meta-analysis, and the message really is immediate cord clamping may cause harm by reducing the chance for survival. And we recommend to make quality improvement plans in your own units and audit your own practices. So I would like to thank all the colleagues who have supported me in my research and the BAPM working group for working so diligently on the toolkit. Thank you very much for your attention.
Hi, I'm Charlotte Sullivan and I'm a consultant obstetrician at the Great Western Hospital in Swindon, and I'm going to talk about how we implemented and have embedded optimal cord management at preterm caesarean section. So in 2016 we did a retrospective audit looking at babies born prematurely in our unit, and we realised that only 12% of them were receiving optimal cord management, of which majority were at vaginal birth. We also performed some structured interviews to the wider members of the perinatal team, and from this we realised that there were 4 main barriers stopping us doing optimal cord management, and so I'll look at these in more detail. Firstly, the obstetric and the neonatal team were working very separately in their own silos. In theatre, the obstetric team were generally scrubbed around the operating table, and the neonatologists were in the corner of the room around the resuscitaire. The obstetricians, when they delivered these very premature babies, were really quite scared and wanted to get the baby to the neonatologist as soon as possible so that the baby could be resuscitated. And equally, the neonatologists wanted the baby to be brought to them as soon as possible so that they could stabilise the baby. And so we worked out really what we needed to do was work more as a perinatal team and bring the neonatologist to the baby at the operating theatre table rather than take the baby away to the neonatologist. Providing good thermal care was also a priority, and our theatres can be quite cold sometimes, so we realised that we needed to be able to change the temperature when we were anticipating a premature birth. Looking at our theatre layout, it was also apparent that the resuscitaire was living in the corner of the theatre, as you can see in this picture. But actually the gases, the gas outlets, were in the centre of the room, which did mean that we could bring the resuscitaire quite close to the operating table. We also realised that we would need to get appropriate equipment ready and get some equipment that was sterile, such as a plastic bag for the very premature babies or a sterile towel for the slightly older ones. So the first thing that we did was try to build a really strong perinatal team. And so we did some team building events. This is one of the mud runs that we did. And we did a lot of training together and simulation. We also problem solved and did some brainstorming as to how we could implement optimal cord management. So we realised thermal care was important. There are some dedicated alongside neonatal resuscitation trolleys which are available, but these are expensive, and we also had concerns that sometimes the premature babies have very short cords, and it may be difficult for the baby to reach the trolley. So we looked at what else we could use. There are transwarmer heat pads, which are relatively low cost, but these aren't sterile, and so we brainstormed how we could create a sterile field. And initially we put them on top of a mayo stand and also a patient's food trolley, but these wouldn't fit under the theatre table, so that didn't work. We then just put the transwarmer inside a mayo table drape and put it on the patient's legs, and this seemed to work quite well. We had to try and source some sterile wraps for the baby. There weren't any bags, but we did manage to find a Burns wrap which worked well. And then a little bit later on we managed to source this NeoHelp thermal heat suit, which worked really well. In fact, so well that we realised from our data that we were actually overheating babies when this was used in conjunction with the transwarmer. And so we stopped using the transwarmer. So this is what we now do. We have a scrub neonatologist. They will take a clean mask and tubing from an assistant who's not scrubbed, who opens it with an aseptic technique. They pass the tubing back to that assistant who will plug it into the resuscitator, and between them they will check that, do all the safety checks. The neonatologist will then stand next to the obstetrician, and in our case it's the assistant obstetrician. When the baby is born, the obstetrician and the neonatologist will put the baby into the heat suit, which is on the patient's legs, and the neonatologist can then provide airway positioning and PEEP. We realise that it's really important everyone knows what they're doing, and so we usually do a pre-brief before the caesarean section, and also go through what everyone's roles are during the WHO checklist. So embedding practice is really important. We have done lots of education with the staff just to really stress how important it is that these premature babies get optimal cord management, so that everyone understands the reason that we're doing it. And we've also do little talks on our prompt, which is our emergency obstetric emergency training days. We have champions in each area, so we have midwives, obstetricians, neonatologists and neonatal nurses, so that they can promote optimal cord management. We've created SOPs, which include the sort of pit stop diagram that you saw in the last slide, which is based on Formula 1. We have regular simulation, so that we can train together. And we've also created a video so that it's available on our intranet, and people can access this whenever they want to refresh how to provide OCM. And when we have new starters or our doctors rotate, we will tend to do some more training or simulation. So this is some data that we've collected. I'm afraid it's not the most up-to-date data. Looking at the x-axis is the dates that these babies were born. The y-axis is the number of seconds of optimal cord management that the babies receive, and each dot is an individual baby. We introduced this technique in 2017, early 2017, and you can see that prior to this, the majority of babies were not getting OCM, but after this, the majority are getting at least 60 seconds, and we've managed to sustain this change. So finally, just a thank you to our great perinatal team, and for our simulation team in Simpatico who helped us create our training video. Thank you.
Good afternoon. After reviewing the benefits of optimal cord management, you may now be considering practice in your unit and whether anything needs to change. Over the next few minutes, I would like to share with you aspects of our maternity services journey introducing optimal cord management. Maternity Northumbria supports nearly 3,500 births per year. Preterm births occur at our obstetric unit, which is supported by a nurse-led Level 1 special care unit. In the 1950s, Virginia Apgar, pictured here, advocated assessment of the newborn 1 minute after birth following cord clamping. Early clamping was thought to reduce the risk of respiratory depression in the newborn caused by the potency of the maternal analgesic and anaesthetic agents used at that time. Initial moves to clamping early also resulted from the increased use of active management of the third stage of labour using oxytocics. Mr. David Hutchin, an experienced obstetrician in the North East, presented a practice viewpoint within our local teaching session and discussed how immediate cord clamping may in fact cause harm. By articulating how the placental transfusion can improve an infant's transition at birth, we went on to consider optimal cord clamping as a potential solution to a persistent problem. This problem being a small but significant number of term babies requiring admission to special care for a short period. Few of these babies needed active resuscitation at birth. These babies were often tachycardic, pale, and looked poorly perfused. Many required fluid bolus to improve. Until we considered the timing of cord clamping, we accepted that these admissions were unavoidable and thought as a perinatal team that we could do nothing to avoid them. With optimal cord management, we soon found that these hypovolemic babies would transfuse themselves if they were left alone. Optimal cord management assisted our babies to make a better transition by avoiding a decrease in cardiac output and a decreased blood pressure caused by immediate cord clamping. Experience from our unit suggests that one professional group cannot effectively introduce optimal cord management in isolation. We started with a small core group of one ANNP, one obstetrician and a midwife. We led by example in the delivery rooms. As our neonatal team is quite small, sharing information on the benefit of placental transfusion was relatively straightforward. The number of babies having optimal cord management increased dramatically as midwives and obstetricians saw that the neonatal nurse practitioners were confident enough to leave the baby with an intact cord. The obstetrician was able to influence obstetric medical trainees' behaviour and that of her colleagues, and this was also the case with the midwife who worked within one of our freestanding birth centres. Did it make a difference? We undertook a comparison of our practice compared to the old practice. The number of infants receiving resuscitative measures dropped dramatically from 15% to 4%. We attributed that to two reasons. Firstly, optimal cord management allowed for a smoother cardiorespiratory transition to extrauterine life. Secondly, the very act of racing to cut the cord allowed the vast majority of babies who were mostly term to establish breathing for themselves. This meant that only those that required resuscitation actually received it. Compared to 2009, there is now an emerging body of literature pertaining to the benefit of optimal cord management. This is useful in addressing any concerns about optimal cord management held by the woman or her healthcare professionals. The QI Toolkit was designed to support teams in overcoming challenges in delivering optimal cord management in babies of less than 34 weeks gestation. Although universal introduction of optimal cord management has a sound evidence base, remember that even the most rational change may fail to occur or be sustained if its implementation is poorly planned or inadequately negotiated. A discussion of intact cord resuscitation is beyond the remit of this toolkit. Northumbria has resuscitation platforms available, so we do have the option of commencing support without being required to clamp and cut the cord to move the baby. However, even without such devices, optimal cord management of 1 minute does not delay intervention. Initial newborn life support, the drying and wrapping of the baby in accordance to gestational requirement, assessment of baby's colour, breathing and heart rate, and optimising head position when done in a timely manner by a competent clinician will take around 60 seconds. The illustration here is the front cover of the National Newborn Life Support Manual, and it serves as a good illustration as to what families typically see should the baby be removed from the bedside. This baby could be receiving advanced resuscitation or could merely be being dried off and being undergoing assessment. Unless continuous dialogue is maintained between the team and the family, they would have little idea as to what was actually going on. Qualitative studies to date, looking at the parental experience of having their preterm newborn baby cared for close to the mother during optimal cord management, have determined that they found it stressful, but they appreciated their inclusion. The Plan, Do, Study Act cycle provides a framework for developing, testing and implementing changes that may lead to improvement. Other tools are detailed in the toolkit, but this is the one that was extensively used within our unit. Application to some issues relating to optimal cord management may give you some idea as to how to overcome some barriers to embedding it into your practice. An example being within our unit, optimal cord management was slow to get off the ground in the obstetric theatre. We started looking at this by deciding to measure the rate. By doing this, we could measure the success of any action that we undertook. We looked at the process of optimal cord management and all those who may be involved. Although we could determine that optimal cord management had been recorded as being undertaken for 20% of babies at caesarean section, we checked the record keeping and put prompts on paper and electronic records to improve data capture in order to address any issues of underreporting. We also shared information on optimal cord management rates and how we may improve them on the team communications. We scoped all the professional groups with a stakeholder interest in optimal cord management. We attempted to allay any worry the midwives or medical staff had about delaying intervention by ensuring an experienced nurse practitioner comfortable with promoting and leading optimal cord management was present at each high-risk delivery. As they infrequently attended the obs and gynae teaching, the theatre teams had not been effectively informed of optimal cord management. Following information sharing, we soon learnt scrub practitioners could influence optimal cord management. They were seen to prompt obstetricians to delay cord clamping and to support the neonatal team in optimising thermal stability once they understood and appreciated what we were trying to do. From our experience introducing optimal cord management, we learned a few things. Firstly, the introduction could not be down to an individual or a specific professional group. And secondly, it was important to depersonalise any objection and avoid unnecessary conflict by identifying issues as considerations. If you want your change to be incorporated into practice, they all have to be addressed, so you may as well welcome them and address them in order of priority. Remove barriers, real and imagined, as much as you can. For example, we addressed the ambient temperature of delivery rooms early to quash any objections to optimal cord management that concerned potential heat loss. Finally, you do need to celebrate good performance. Your team needs to hear how well they've been doing. Our success is attributed to interprofessional working and a positive perinatal team culture within our unit. Thank you for listening. I look forward to your questions and comments.
Hello, my name's Amanda Burley and I'm a midwife. I'm here to talk about optimal cord management in preterm babies and the midwife's role in implementing evidence into practice. So what is the change and why? The change is resuscitation with an intact cord, and that means leaving the cord intact for at least 1 minute in preterm infants, starting with resuscitation with such as inflation breaths or intubation before clamping and cutting the cord. And why are we changing this practice? We're changing because the evidence shows that immediate cord clamping increases mortality rate by 30%, and optimal cord management results in a reduction in hospital deaths by 27 to 30%. You'll have already had some of the consultants talking about the benefits of optimal cord clamping for premature babies, so this is just a refresher. Optimal cord management decreases intraventricular hemorrhage, decreases necrotizing enterocolitis, decreases late onset sepsis, decreases blood transfusions, decreased need for ventilation, with an increased hematocrit, increased hemoglobin, increased blood pressure, and increased cerebral, lung and organ oxygenation. We'll talk about the role of the midwife and the multidisciplinary team. It's quite difficult to talk about just the midwife's role because it is really essential that there is a multidisciplinary team approach in implementing the change and implementing optimal cord management. Midwife's particular role is in antenatal education, and this is making parents aware of optimal cord management, particularly parents whose babies are at risk of preterm birth. These parents should receive information about optimal cord management when they are receiving antenatal counselling about their imminent preterm birth. An additional section could be added to the notes birth plan as a prompt and to record that the information has been relayed to the parents. Other units have developed parent leaflets to support verbal information of perinatal optimisation interventions, which include information about optimal cord management. Parents as change agents, I found in my experience that parents as change agents are extremely important, and involving the parents in decision making, thereby ensuring truly informed consent by sharing the evidence that shows optimal cord management improves their babies' short and long-term outcomes. This also fosters good communication and partnership in care between parents and professionals. And in my experience, I've never met a parent when given the evidence about the benefits of optimal cord management who has not been on board. And in my experience, educated parents have been some of the biggest change agents, and we need to involve them much more. When we're implementing optimal cord management within a unit, there are steps to success. A growing number of units have already established optimal cord management methods and protocols, and these should continue. Fundamentally important is the development of a multidisciplinary team involving neonatology, obstetrics and midwifery. And we need a proactive, collaborative team dedicated to intact cord resuscitation, and this is essential for effective implementation. A new delivery room protocol written according to locally possible settings and available equipment with agreement and collaboration, and mandatory interdisciplinary education systems with simulation training. Midwives could take responsible for ongoing training, incorporating staff and new starters from all multidisciplinary areas, and this should continue from the onset and there forwards. On Delivery Suite, midwifery optimal cord management champions, who are practitioners passionate, confident with the evidence and methods until optimal cord management is firmly embedded into practice, and their role would be to support the setting and support other practitioners who are less confident in the practice until it becomes embedded into practice. And following embedding into practice, following up with audit of the unit's own practice. Preparation for delivery. There should be pre-birthing planning with the obstetric, midwifery and neonatal team and informed and consenting parents. Prior to birth, there should be decision making decided regarding the optimal delivery position, maintaining the women's privacy as far as possible, and location of equipment, again involving parents and getting their consent. Ensuring that the necessary equipment is available and necessary standard checks are completed. Midwives should be a commentator of events, keeping time and supporter of the parents. Third stage management options, which are a midwife responsibility, should be discussed and consent obtained following by discussion with the medical team. The mother should be reassured that administering oxytocin drugs and optical management do not increase risk of postpartum hemorrhage or retained placenta. And documentation. Parents should be given reassurance about their baby's well-being and at delivery be encouraged to touch or even hold their baby with clean hands where this is possible. One of the obstacles to implementing optimal cord management has been baby's temperature, so there is a thermal consideration to take into point. The room should be warm, ideally between 24 and 26 degrees. There should be warm sterile towels available for holding baby during optimal cord management and later transfer to the stabilisation area. And if gestation requires it, ensure that sterile plastic bag or thermal suit is available for use. Ensure that the heat source, transformers or thermal mattresses on stabilisation trolley are switched on. And there should be a warm, well-fitting hat for after delivery. Baby's temperature should be checked after optimal cord clamping is complete, ideally with continuous temperature monitoring. There are very rare contraindications to optimal cord management, but rare justifiable contraindications to optimal cord clamp management include maternal resuscitation in the face of massive acute hemorrhage, or a ruptured vasa previa, a snap cord, or any other trauma to the cord vessels which will result in hemorrhage from the baby. In special circumstances, such as complete placental abruption, where the placenta is delivered at the same time as the baby, the midwife could hold the placenta above the baby, then clamping at 60 seconds before the placenta is lowered. Umbilical cord milking may also be considered at this situation. Things that aren't contraindications for optimal cord management are a short cord length. A short cord length might interfere with the management of the mother or baby, but can usually be addressed by optimal positioning. Short cord length is not a consideration for early clamping, and even if the cord is really short, a lot of time can be used drying the baby, making sure that the hat's on, giving that baby optimal chance to have optimal cord management. Multiple gestations. Studies of multiple births have demonstrated feasibility of providing optimal cord management to twins and triplets 28 weeks to 30 weeks. Multiple births should not be routinely excluded from optimal cord management, and plans for delivery should be considered by an experienced perinatal team on an individual basis, with a decision made ahead of birth. The most important aspect of implementing optimal cord management into practice is a team approach of the obstetrics, neonatology and midwives all working together and including the parents. And this is essential with good planning. With good planning, there's no contraindications to bringing optimal cord clamping into practice. And as we've seen from the evidence, it could save 30% of babies' lives.
Hi everybody. So I think as we've lost Grenville, Heike, would you mind leading on the Q&A? So
that's fine.
The first question was for Amy. Unfortunately, Amy wasn't able to join us today, but someone's asked when she was told about the cord clamping and how long before it was that she gave birth. So I just wonder sort of if people could talk about the normal practice.
I might be able to answer that one a little bit, because Amy was born in our unit, and as part of our sort of QI project at the time, we had implemented a package of care to optimise premature babies, and part of that process was intrapartum counselling. So when women came in labour, we did some joint counselling. So the obstetricians and neonatologists will counsel the women for several aspects, one of them being optimal cord management, but also early breast milk, etc. And so that would have been done when she came in established preterm labour, I believe.
Thank you. I think we've got Grenville back now. Do you want to try talking again, Grenville, see if we can hear you without the echo this time? Yeah,
I'm very sorry about that. Hopefully you can hear me now.
Yeah, we do.
And apologies for all the technical issues. Teams is definitely not my best friend today. And the next thing, Kate, is I can't see any of the questions. So
well, why don't I read the questions and you can point them to the right people for us. So the next question is prenatal counselling regarding optimal cord management part of routine practice?
I think probably one of the perinatal, wider perinatal teams rather than neonatologists is better to answer that. So, and Charlotte, are you there?
Yes. So in our unit, it is part of our routine practice. So we have a little bundle of care. The midwives will call the neonatologist as soon as a woman comes in and suspected preterm labour, or if we're anticipating to have to do a preterm caesarean, and they will get full counselling at that stage. Yeah. But we don't do routine counselling for all women antenatally.
It's like the same for us. We also, when we counsel the parents about what to expect with a preterm infant, we also counsel them about optimal cord management.
Then the next question says, does it matter if the baby at birth is above or below the placenta?
I saw this question earlier. I thought, Heike, you're probably best to answer this from an evidence-based point of view.
Yeah. So the early studies on in preterm infants were based on studies done in the 1960s by Yao and Lind, where people showed, they seem to show that if you make use of the gravity and hold the baby below the placenta, then more blood goes into the placenta. However, and now, so first of all, if you have a baby was delivered by cesarean section, it's often there's a limit on how far you can hold the baby away from the placenta with the cord length. And now the recent study, there's one by Nestor, which actually shows that it does not matter. It's not compulsory to hold the baby below the level of the placenta. So there can still be, because if you keep the cord open, there will be always a sort of pressure between the placenta and the baby. And we now more think that transfer of the blood is actually enhanced by the baby starting to breathe rather than gravity. And then obviously contractions of the uterus come in as well. So it's not compulsory anymore to hold it below the level of the placenta, even though lots of people did that as we were sort of in belief that this is necessary. But but you shouldn't hold the baby up very high above the level of the placenta, because then obviously more blood can go in from the baby into the placenta. It goes backwards as well. So on the level at the level will be, or just above when you're in cesarean section, will be fine. Thank you,
Heike. That's very clear. I've got the questions now, so I'll read out the next question. I think I was going to ask George this, because I think George alluded to this in his presentation. So are the features we should use in preterm neonates to confirm we safely continue DCC over immediate resuscitation, e.g. heart rate?
I think basically what I think people should remember is whatever condition the baby's born in, it does take, can take up to 60 seconds to, wrap the baby in the polythene, dry the baby's head, put the baby's hat on, assess the baby, open the baby's airway, and by the time all that's done, no matter what condition the baby's born in, that will take, if you do that, that'll take almost a minute. So you're probably almost there in providing 60 seconds of optimal cord management. Because what you've got to remember is, if we go back to historically, very little babies born, obstetricians and midwives quickly clamp, cut, throwing a baby at you. You've got to do all those things somewhere else, and anyway, you've got to wrap them up properly if they've been handed to you very quickly, and you've got to think about putting hats and things on. So you might just, it's a good idea just to get, you can do optimal cord management quite nicely just by making a plan, making an agreement with everyone around you as to what you'll do at the woman's bedside. Bearing in mind, you're a stranger, you've come in at the end of a delivery and you're up close and personal with this woman who's just had a baby, and as long as it's, as long as it's planned and it's negotiated and the family know what's going on, it normally works quite well.
Any other comments on that? Thank you, George.
Now, I fully agree with that. I mean, obviously, it would be nice to have a heart rate immediately after birth. We are working on that, but the technique is not quite available yet. So just trust the baby that they start, stimulate them, as George said, wrap them up, and put the head on, and that takes some time. And by the time they will start breathing anyway.
Thank you, Heike. The next question is about data that's collected on optimal cord clamping, cord management, I should say. Which staff are responsible for recording this? So I know that data is collected, I think, from this year onwards for NNAP. And so that data all comes via Badgernet. So the responsibility lies with the neonatal teams to record that data. However, the gestational age upper limit for that is not 34 weeks as we described in our framework. I think it's 32 weeks. If anyone can correct me on that, I think it's 32 weeks.
Well, actually, on Badgernet, it doesn't give you a limit. It's all babies who are admitted. So
no, but for NNAP, it's 32 weeks.
Oh, I see. Okay. Well, what's the analyze also? Okay. The problem is to get the notification from the midwives or the, who have delivered the baby if one couldn't observe it. For example, now in COVID times where we have to stand outside in some of our rooms. So we have to rely on the midwives to tell us what was actually happening.
So thank you, Heike. The next question is similar. I guess that, again, the data that's being analysed at the moment is limited by that upper limit of gestation. So it doesn't collect information on babies of higher gestations. I don't know if anyone thinks we should lobby to change that perhaps, or whether there should be more than one set of data collected at various gestations.
To be honest, I would be of the opinion to collect it for every baby, including the term ones, because then it gets to in everybody's head that this needs to be is a basic data set similar to birth weight or APGAS to be collected for every baby, and then it will be automatic. That would be the ideal word, to my opinion.
Any alternative opinions to that? I think I agree with that, Heike. I think that I can't see a good reason to limit it to 32 weeks, apart from the fact that the benefits may be greater at lower gestations. So the next question is, I think, again, that's going to go to you, Heike, from an evidence-based point of view. Are there any babies that optional cord management could be harmful for? So the different types of twins in placental abruption, etc. I think you alluded to some of this in your presentation.
Yeah, and Amanda gave the other things. So really, I mean, the message is that immediate cord clamping is harmful. There were some, I mean, in the early studies, we were thinking about not including babies with high drops, for example, with rhesus incompatibility, maternal HIV. But that has now been proven that actually those babies definitely benefit. There is a paper coming out also on babies with intrauterine growth retardation, where they demonstrated that's feasible in those as well and do not have massive side effects. There are some papers on twins now. There's still a bit of discussion with monochorionic twins. I think, but there's one paper coming out on twins as well, which shows at least a feasibility on it. So, and there are now studies underway. Also, studies very important. Babies with cardiac disease, congenital cardiac heart disease, they actually benefit a lot because they need high hemoglobin values to transport oxygen. You know, if they have a mixed defect. And there are studies going on also with babies who have diaphragmatic hernia at birth, so stabilization. And the other big group would be babies with HIE. And for those ones, we would really need large trials. And there's some pilot studies going on in Sweden, for example. So we don't have much data on those, but I cannot really envisage any baby who would not benefit from who will be harmed by lead cord clamping. Not really.
So Heike, can I come back to you on that last point? So if a baby is born after I don't know, in very poor condition with very low or no heart rates detectable after a intrapartum event of some sort, what would you say then? I mean, you say that the Swedish study is collecting data on those very small numbers at the moment, but until we have better evidence, what would be your suggestion?
Well, my preferred suggestion would be that these babies need delayed cord clamping to optimize their blood volume, circulating blood volume. If you think about the resuscitation of these babies, what do? We give volume, isn't it, if they are hypotensive. And they need the organ perfusion to actually, especially the heart and lungs and the brain, to be perfused. So instead of giving a, bolus of, sometimes blood if they have low hemoglobin or some volume, it's much better to have it in the physiological approach and get their own blood immediately. And it's much quicker. You have it immediately. So actually that's the resuscitation, basically the really life-saving resuscitation, I would argue, is the case that they get their delayed cord clamping at birth. But of course, that again, needs a lot of changes also for us to psychological changes. And I hope that this toolkit actually initiates some MDT working also for the older babies who have, poor HIE and so forth. But we need more studies on that as well. There was a very nice study done in India, where they did a crossover trial, the blockwise randomization, and they showed better in term babies with HIE, and they have shown a better survival rate. They didn't have the means to do the MRIs, unfortunately, but they definitely showed better survival rates.
Thank you. And this, I'm going to bring the next two questions together. So there's one comment that delayed cord clamping is part of Resuscitation Council UK guidance. But then another question, and I guess this is for both of you two again, suggesting that the evidence showing that resuscitation before clamping the cord is better than just waiting while we try and stimulate breaths. And I guess your emphasis was on resuscitation on the cord. Can you explain that?
Yeah, so I would more follow the guidance or the study which Anu Kateria showed, where he compared delayed cord clamping with a simple stimulation to delayed cord clamping with giving some resuscitation breaths. And he could show that 90% of all babies will actually breathe by 1 minute of age. So I think there's a bit of a misunderstanding that we emphasize too much this sort of resuscitation with the intact cord. I think that's in the moment it's mostly done. I mean, some people have done some studies on it and they're confident with it, and it obviously needs a very much a multidisciplinary approach, and maybe also a device to help with that. And I would much favor to think about this, what I also emphasized in my talk, that we are thinking about physiological adaptation in a preterm baby, which is somewhat different from a term baby because they need a little bit more time. So what we are advocating is really give them the time for the 1 minute, sort themselves out. Most of them will start breathing. You can see that. They won't start breathing in the first second, and they don't need to because they're still connected to the placenta. So as long as the mum and baby and placenta are all connected, the mum will actually provide for the baby. And the baby comes into a cold environment, so they get a bit of a cold shock. They realize they have to do something by themselves, and which they do. And the majority of them will actually start breathing if you stimulate them a little bit, or some just do it anyway. So I think that's what we should maybe we have talked about that this resuscitation with the cord intact is also possible now, but I think we do not really know what would be the right order of events. There's another meta-analysis just come out where people looked at the prolonged inflation breath of 5 seconds, and that actually has shown that the babies who had this prolonged inflation breaths had higher mortality rate. So if we're giving some breathing support, we should be really careful, and maybe the right way is just to give them a bit of CPAP, before they are ready to give to take their first breath. And if they're taking their first breath, then they redirect the circulating blood volume into the lungs. The lungs have to open up, the capillaries have to get straight and start prepare for oxygen exchange. So there's still lots of open questions, so we can't really say what would be the right sequence of events if you want to do a full resuscitation. But again, trials are ongoing for that. There's a large randomized trial going on in the Netherlands, just looking at that. That's why Untitled is doing that. So that will be soon available.
Thank you. I think this next question is perhaps one that Charlotte, you may be able to address, which is that of, because I think it's referring to C-sections. So where there's a sterile field, how do you deal with the fact that the bag that we put the baby in isn't strictly speaking sterile, and then we put a hat on and use other bits of non-sterile equipment? What are the practical tips for getting around those various issues?
Yeah, so at vaginal birth it's quite easy because you can just use the standard plastic bag, but this is what we struggled with at cesarean section, and hence trying different techniques. So different units will use, that I've worked with, will use different things. So things like Burns wraps we used initially, which is just a sheet of plastic which is sterile that you can wrap around the baby. The Neo Help suit that we now use is sterile, and so we can use that at cesarean section. But some units have used sort of suction bags, which are used for other things, which are sterile, and they've cut the top and the bottom off and even cut little arms for holes. Someone else has asked about no, sorry, you said about the hat. So we wouldn't use a hat. We would wrap, the Neo Health suit has a little hood which is can be tightened up. But if you've got just a sterile bag, you can sort of wrap it around the baby's head. We've also had we also have some sterile blankets that you can buy, and again those can be wrapped around the baby to keep it warm.
Thank you, Charlotte. I'm not sure if I'm seeing the questions in order now. There's a question regarding chord prolapse. What should we do in the event of chord prolapse?
Shall I answer that one as well? So with chord prolapse, obviously it can cause acute fetal distress, and so we want to deliver the baby as soon as possible. But not all babies will be distressed, and I think the key thing is once that baby is delivered, is especially if it's premature, you'll want to stabilize that baby. So getting it into a warm environment, and if necessary, providing airway support. And if that baby doesn't breathe, I would start some, not me personally, would start some inflation breaths. So that initial period probably takes 40 seconds to a minute, and then you can clamp the cord. But I think it's still important that that baby gets the optimal cord management. I don't know whether, Heiko, have you got any?
No,
George,
I think you fully agree. Yeah.
Yeah, hi. I've been to 2 preterm deliveries that were chord prolapses, where we actually still delayed the clamping, cutting and the clamping of the cord by a minute, because we just continued to do what we would normally do. You know, position the baby appropriately, wrap the baby appropriately, you know, cover the baby up, assess the baby, and then move the baby. And you know, without any, there wasn't any adverse effects. We just continued doing the same, just like what Charlotte said.
Thank you. Heike, did you want to add to that?
No, thank you. I agree.
Okay. Question I missed here is about chorionic diamniotic twins. Is that a contraindication for optimal cord management? And what about twin-to-twin transfusion in that situation? Anyone, I guess, can answer that.
So in my experience, twin-to-twin transfusion is usually picked up earlier in the antenatal period, and babies may have management of that with fetal medicine, be that by lasering the cords or whatever. It can still, there is still a theoretical risk of acute transfusion at the time of birth. So I think obstetricians would be a bit more wary about monochorionic twins, but think I'm going to be corrected here, but there is some initial data which is reassuring about monochorionic twins.
Yeah, I agree. There are now studies coming out on those as well. So obviously, the obstetrician will still look at the babies when they're coming out, but in principle, we plan for optimal cord management in those as well.
Okay, thank you. So this is a question from Ashley with regards to using the near help. Is the infant then placed onto the mother's legs? And how do you achieve optimal positioning for airway stabilisation in that event? Who's got experience of using near help?
Me to a degree, but I'm an obstetrician. So yeah, we will deliver the baby into the near help, and it'll be usually positioned just below where our cesarean section drape, the little bag that collects the fluid. And so it's probably on the mum's lower abdomen, pelvis, stroke top of the thighs area. And actually, generally, it's a relatively stable base. And again, part of that time is just wrapping the baby adequately and then assessing it. So the actual time where you might need to give any respiratory support is quite short. But we haven't had any problems with it.
George, have you got anything to add to that?
No, we would just do it at the operating table exactly the same, and we've had no issue. Just like what Charlotte said, you know, by the virtue of them being very preterm, it's not like the big term babies that can lie on mum's thighs. Where they're having some optimal cord management, you know, the babies are still very close to the incision, so it does take a bit of negotiation and working with the obstetricians, but it's very manageable.
Thank you. A comment here, from what I understand, the cord clamping should be delayed until lungs have been inflated. Why do we then ask for cord clamping to be delayed for 60 seconds? I think that should say at least 60 seconds. Any comments on that?
Well, I think we put that into it to give some idea or some guidance. Ideally, we would very much like to delay the cord clamping even further than the 60 seconds. We just wanted to put something in for people to orientate, but I would not clamp just because the baby started breathing. If you give them a few more breaths, even if they start breathing in 20 seconds, let them have another 40 seconds so they can sort out how much blood they want and to fill up the lungs and give them some time. So the idea is not to rush.
Okay, thank you. This is a comment from Oliver Rackham. I like the idea that Amanda used, that immediate clamping increases mortality and compares that to prone sleeping, reminding us that it is the abnormal intervention. I think we all agreed with that when we wrote this framework, and tried to use a form of words that emphasise that. I think we would all completely agree with that. And another comment that 90% of babies breathe in the first minutes. They don't need mask ventilation, just stimulation and encouragement. And again, that's something that we did emphasise in that section of the framework as well. I think I've come to the end of the questions and comments, unless I've missed any, Kate.
No, I think you're good. So maybe just if the speakers have anything else they'd like to say that they haven't said yet.
Just encourage. We would like to encourage everybody to, start implementing if you haven't started yet. And all the Toolkit authors are happy to answer questions individually. I'm not sure whether our email addresses are in the Toolkit, but very happy to help.
It can be found easily.
Yeah.
Thank you, Heike. Thank you. Well, I think we've almost stuck to time, and I'd just like to very much thank all of the speakers and contributors again. Despite the technical hitches, limitations, and the vagaries of using Microsoft Teams rather than meeting in a room together, I think this has been really useful, and I've certainly learnt quite a bit over the last few months contributing to this, and hopefully it's been of benefit to everyone else. Thank you very much. And also thank you to Kate and to Marcus for facilitating this, and to Jamie for sorting out some of the IT issues that we've had. So thank you, everyone.
Thank you.
Thank
Enjoy
you.
the rest
Bye-bye.
of your afternoons. Thank you. Bye.
Thank you.